Good morning. My name is Kiran Khush from Stanford University, and it's a great pleasure for me to present today to the Asia Pacific Cardiovascular Intervention and Surgery meeting. I'll be discussing the revised framework for heart transplant allocation in the United States. A general overview of my talk, I'll be discussing the principles governing organ allocation in the US and reasons for modification of the prior system, which was implemented in 2006. I'll give you a summary of the revised donor heart allocation system, which was rolled out in October 2018, and will then spend the majority of my time discussing the impact on the use of temporary and durable mechanical circulatory support, waiting times for transplant, procurement distance and ischemic time, post-transplant survival, the number of exception requests, and special patient populations. So the framework that really guides organ allocation in the United States is called the Final Rule. This is the national policy that established the protocol for organ donation, and it directs the organ procurement and transplantation network to develop policies for organ allocation that seek to achieve the best use of donated organs, avoids wasting of organs, and promotes patient access and efficient organ placement. It shall set candidate priority based on objective and measurable medical criteria, and this framework should distribute organs over a broad an area as possible. So the reasons why we had to modify the prior US donor heart allocation system was that too many candidates with varying levels of severity were lumped together in the most urgent status, which was status 1A. There are a very high number of exception requests. The previous policy did not account for the increasing use of mechanical support devices, particularly temporary mechanical support, and the geographic sharing scheme was felt to be inequitable and inconsistent with the final rule. So as you can see here in this figure, that of all patients who were lumped together in this high priority status or status 1A, there was greatly variable mortality, ranging from relatively low mortality for patients on durable MCS or LVADs to high mortality on patients on temporary MCS or mechanical ventilation. So clearly there was a great difference in disease severity within this one category. We also see here that the number of exception requests to get patients to this high priority category was going up year on year. The United States is divided into 11 transplant regions, and the proportion of patients transplanted as a status 1A varied slightly between regions, but was generally about 70% of all patients transplanted in the US. And finally, we know that use of mechanical circulatory support has certainly changed over the years, and a priority system should really account for these changes. We also know that patients on temporary MCS, such as those on ECMO, have much poorer survival than patients on more durable mechanical support and should be more highly prioritized for transplant. So these are the major and minor changes made to the US donor heart allocation system in 2018. The major changes were that we described 6 new medical urgency status classifications. There's a broader geographic sharing of donor hearts, and now requests for exceptions are reviewed outside the region rather than within your own region. And the primary goals of this revision were to better stratify patients according to their waitlist mortality, to improve access to donor hearts for the most ill candidates, and to reduce the burden of exception requests. So the prior status 1A is now divided into 3 statuses. Status 1, which is the highest tier status, are patients on VA ECMO or temporary biventricular support. Patients for status 2 have intra-aortic balloon pumps, endovascular mechanical support that's temporary, total artificial hearts, BiVADs, and RVADs. And finally, status 3 patients are stable LVAD patients who have a discretionary 30 days as a status 3, patients on high-dose inotropes who have continuous monitoring in the hospital, and MCS-related complications. The new status 4, which is equivalent to the old status 1B, are patients who are on inotropes without continuous monitoring. They can be at home, patients with dischargeable VADs, and then special patient populations such as retransplants, congenital heart disease, refractory ischemia, hypertrophic cardiomyopathy, amyloid, and restrictive cardiomyopathy. Now, multi-organ transplants now have their own status, which is status 5. And finally, there's also a status 6, which is all remaining patients. Now, it's important to know that patients have to meet specific hemodynamic criteria to qualify as a status 1 or 2. So these are hemodynamic criteria consistent with cardiogenic shock. And if they don't have hemodynamics, they have to have some of these other parameters indicating that they're truly in cardiogenic shock. So we're really trying to tighten up the criteria for the highest statuses. And to continue as a status 1 or 2 beyond 1 week, you have to continue to meet specific hemodynamic criteria showing that you're still critically ill and you have not been stabilized. Not surprisingly, the use of temporary mechanical support has dramatically increased in this new heart allocation system. So the use of ECMO has gone up from 4.6 to 6.8% of waitlisted candidates. And dramatically, the use of balloon pumps has gone from about 13 to 29%, while the use of LVADs and other durable MCS has decreased. This is shown here, showing that the use of temporary MCS in general cardiac ICUs has not changed much over time, but it significantly increased at transplant centers, specifically for balloon pumps. And similarly, we've seen very dramatic decreases in the use of durable LVADs as a bridge to transplantation. Certainly at Stanford, which is my center, we do very few bridge to transplant LVADs these days. Our patients mainly go straight to transplant, or they may go to bridge to eligibility LVADs or destination therapy LVADs. So as I mentioned previously, almost 70% of patients used to be listed as a status 1A. Now we have more even distribution across these statuses, which is likely more equitable. We also know that we are prioritizing the sickest patients. So status 1 patients indeed have the highest waitlist mortality. They're the most ill. Status 2s have the second highest waitlist mortality, and so on. And fortunately, we are transplanting these critically ill patients. So transplant rates are highest for status 1 and status 2 patients, followed by status 3, as the system was designed. The median day to transplant has dramatically decreased in the new system. So status 1A used to have a median waiting time of about 2 months, and status 1B was about 8 or 9 months. Status 2s, or the lowest priority system, was over a year. Currently, status 1s have a median waiting time of 5 days, status 2 of 9 days, and status 3 of less than a month. And this has been my personal experience at my center, where if we list a patient at status 1 or 2, they're typically transplanted within a week. And so patients do not have to remain on temporary support for very long. This waiting time does vary somewhat across the country, but consistently waiting times for transplant have been decreased significantly. Now, hearts are now being shared over a broader geographic area. It used to be that most hearts were transplanted locally within about 250 miles, and the rest went out to a maximum of 500 miles. Now, most hearts immediately go out to a maximum of 500 miles, and about 11% of hearts go out as far as 1,000 miles. So we're starting to share hearts more broadly to enable these hearts to get to patients who really need them, the sickest patients. As we can see here, the median distance traveled by the donor heart has increased from 77 to 215 nautical miles. And along with that, the median ischemic time has increased from 3 to 3.4 hours. So there's a lot of concern that we're transplanting sicker patients, patients on temporary mechanical support, and the hearts have a longer ischemic time. So there's concern that post-transplant outcomes would be worse. Fortunately, this is not the case. Data to date show that survival after transplantation is equivalent between the new and the old allocation system. Of course, most of our follow-up to date is only 1 or 2 years, given that the new system was only implemented in October 2018. Unfortunately, where the new system has not had as much success is in reducing the number of status exception requests. Currently, we still have 300 to 400 exception requests, which are about 1/3 of all transplants, and almost all of them are approved, although this does vary a little bit from one region of the country to the next. There is also concern that certain patient populations, such as those who are not eligible for temporary support, such as patients with hypertrophic cardiomyopathy, may do worse under the new allocation system. Fortunately, that has not been the case. This figure shows that waitlist mortality has actually decreased under the new system and transplant rates have increased. So even particular patient populations seem to be doing better in the new system. So in conclusion, the revised US heart allocation system has resulted in a dramatic increase in the use of temporary mechanical support, especially balloon pumps, and a decrease in the use of durable LVADs. There's been a dramatic decrease in median waiting times and an increase in the procurement distance and ischemic time. This has led to an overall reduction in waitlist mortality, an increase in transplantation for the most medically urgent or the sickest candidates, with no significant difference in 1 year post-transplant survival. Unfortunately, there's been no decrease in status exception requests, and I think there are still some patients who are disadvantaged under the new system, such as highly sensitized patients. Now, this is just the first iteration of a new donor heart allocation system. I think we're all working towards eventually implementing a heart allocation score in the United States, which takes into account these patient priority factors, as well as other considerations, such as the anticipated ischemic time, blood group compatibility, age, and so forth. And with that, I would like to thank you very much for your time and attention. It was a pleasure to speak to you today. Thank you.